Well, I want to thank Craig Walker and Arthur Lee, as well as the NCVH crew and team for inviting me this year to give a couple of talks at this year's meeting. I'm going to talk about what does IVUS add and does it improve outcomes when it comes to peripheral interventions. These are my disclosures, nothing pertinent to this presentation. Well, we all know the keys to optimizing interventional therapies include multiple things. You have to have a plan. You have to be able to cross the stenosis or a CTO successfully. Vessel prep is important, whether it's scoring balloons or atherectomy. Obviously, accurate sizing of the vessel that's being treated is very important, and in some cases can improve patency rates when sizing is optimized. We want to obviously treat normal to normal, optimize balloon inflation, as well as stent expansion and wall apposition. And we want to limit the amount of contrast we use to really protect patients' renal function. But we do have challenges, especially when you're dealing with different vessel segments. When it comes to the femoral popliteal segment, you're dealing with long CTOs, commonly with mixed plaque morphology. Sometimes about 35% of these are calcified. We know there's a high rate of restenosis in the SFA, and a lot of this is really due to mechanical stress from rotation, torsion, as well as lengthening, which can really lead to restenosis or even stent fracture and ISR. When it comes to tibial disease, we know we're dealing with long diffuse stenoses and CTOs. These vessels are typically heavily calcified, especially when you're dealing with diabetics and patients with CKD. And there's some early histologic work indicating cartilage and bone in these vessels. So what are the limitations of angiography? As we all know, angiography is really the gold standard and plays really a critical role when it comes to imaging as well as guidance during intervention. But it does have limitations. We know that angiography provides really a 2D image of a 3D luminal structure. It fails to identify morphology and composition of plaque, fails to accurately determine true vessel size, particularly in CTOs, fails to determine adequacy of intervention in terms of true lumen gain or stent expansion or wall apposition post-therapy, and dissections may appear benign or non-flow limiting despite significant luminal compromise. Obviously, IVUS has limitations as well. Availability is a problem. Not everybody has it. Setup time, there's definitely a learning curve for your techs and your nurses and crew that you're working with. Image quality is obviously better with an 035 system compared to an 018, but oftentimes getting an 035 system through a CTO or a small tibial vessel is not ideal. Image interpretation obviously takes time, and there is a learning curve with that. And then there's obviously added cost when using it. But it does have many advantages compared to angiography. It's obviously more accurate for vessel sizing and determining the true size of an artery that's being treated. It depicts the location of calcium and assesses the plaque morphology and composition much better than angiography. It also shows you the extent of disease because obviously we want to try to treat normal to normal to improve patency rates. And the significance of dissections is definitely much better shown with IVUS than angiography. Higher restenosis rates when we know that there are higher restenosis rates when stents are not sized properly. So IVUS can obviously help with vessel sizing and assessing optimal stent expansion and wall apposition post-treatment. And we know that there's some data now showing improved outcomes with less restenosis at 1 year following SFA interventions, which are guided by IVUS, including stent placement as well as atherectomy. So what does IVUS tell us relative to angiography in terms of plaque analysis? Well, this is a nice study that was a prospective study including 93 patients where they basically looked at IVUS versus angiography to determine plaque composition. IVUS was more accurate in determining the vessel diameter and the vessel area stenosis, and was also better at determining the severity of calcification compared to angiography. And here's an example of that. If you look at the angiogram on the left side, it doesn't look too bad. Obviously, there's a little bit of plaque, at least angiographically, but when you look with IVUS, you can see really that there are areas of calcification as well as fibrous plaque and significant luminal compromise. And here's another example of IVUS versus angiography. If you look at the angiogram in box A, you can see it looks like there's really no focal hemodynamically significant stenosis. But when you actually look with IVUS, you can see that there's not only significant fibrous plaque, but there's also significant reduction of the lumen. And a lot of this plaque is really fibrous in nature with some areas of necrotic plaque and a minimal calcification. So it gives you a much better visualization and analysis of what's really going on in a vessel that you're trying to treat. When it comes to evaluating residual disease, IVUS has also been shown to be better in the SFA. There's another study by Hitchner and his colleagues, 59 patients. IVUS was feasible and shown to be low risk and better assessing residual disease and adequacy of treatment compared to angiography during SFA interventions. And here's an example of that. If you look at the angiogram in box A, you can see that that looks like a relatively okay angiogram, and this was post-angioplasty. But when you look at the IVUS of that same segment, you can see there's significant atherosclerotic plaque, a few crests of calcification, and significant luminal compromise here. And this resulted in placement of a stent, which again, with post-IVUS evaluation, showed that there was not optimal stent expansion or wall apposition. And so as a result, additional angioplasty was performed, and then the post-IVUS showed a significant improvement. But when you look at the angiogram after the initial stent placement, you can see it looks relatively normal. And so this clearly was missed on angiography, and IVUS really made the difference in terms of visualizing the proper sizing and wall apposition of the stent. So we all know that this is important. The SUPERB trial, which really studied the Supera stent, showed us that proper sizing of stents, limiting compression or elongation in this case, really optimized patency rate. And so we know that that's important. And so there are some studies, as this is data presented at Charing Cross in 2019, which really looked at 43 patients with symptomatic PAD, 2 blinded investigators, and they looked at basically angiography and IVUS, and was there a difference in terms of determining true vessel size for the vessel that they were going to treat. And you can see when you look at this left column that there was a significant undersizing of the angioplasty balloon or stent that was going to be placed based strictly on angiography compared to IVUS. And this was statistically significant. So you can see IVUS is definitely better at determining true vessel diameter. So here's another study that was comparing angiography versus IVUS in determining vessel diameter. This study was a small number of patients, 43 patients retrospectively analyzed. They looked at angiography compared to IVUS. And again, it showed the same conclusion. IVUS offered a greater degree of accuracy in terms of measuring the size of the lumen and the diameter of the lumen compared to angiography, which was consistently underestimating vessel size. And we know that has implications in terms of primary patency rate as well as patency rate of stents, as we've seen in the past. And here's an example of it. If you look at the angiogram to the left, it looks okay. You don't really see anything that looks too suspicious. There's obviously some atherosclerotic plaque there. But when the IVUS is performed, you can see there's a significant atherosclerotic plaque, there's luminal compromise, and there's a stenosis of at least 60+% here. So this resulted in treating this segment of SFA with a 6mm angioplasty balloon after proper measuring. And although the angiogram looks similar, there was a significant improvement post-IVUS. And here's another example. Again, the angiogram, when you look over here, shows that there's some level of atherosclerotic plaque through this segment. But when you look with the IVUS, you can see there's almost an 82% luminal compromise or stenosis with significant atherosclerotic plaque. And on real time, if you look at this video, you can see that this is very complex morphology and plaque composition. So this clearly requires some level of intervention. Whereas here, we might have just done an angioplasty. This may need something like a scaffold to fix it. There was a subgroup analysis of the IMPACT data, which was comparing really DCB versus angioplasty. And Lita et al. Wanted to really explore the benefit of using IVUS on patency rate. IVUS was used in about 40% of cases. And what they found was that when IVUS was used, the patency rate was significantly better. It was 71% versus 42% for angioplasty and 96 versus 85% for DCB at 12 months. So it made a significant difference in this case. What about stent placement in the SFA and popliteal artery? Well, here's a study that was performed comparing really IVUS-directed FemPop stent placement compared to angiography guided or non-IVUS guided. And what it showed is that it did result in a significant patency benefit. And if you look, this included 234 patients, 28% with CLI. 5-year primary patency rate was 65% in the IVUS group versus 35% in the non-IVUS group, with really no change in mal. And it was really, it showed that there was a favorable impact due to, again, accurate vessel sizing and being able to stent normal artery to normal artery. Here's some data that was really presented by Dr. Spark at Charing Cross in 2018. And again, his team showed the benefit of IVUS plus angiography versus angiography alone when dealing with femoral popliteal interventions. What they did is they conducted a prospective single-center RCT to evaluate the benefit of IVUS plus angiography compared with angiography alone for the evaluation and treatment of FemPop disease. Their study included 91 patients, relatively equally divided between the IVUS group and the non-IVUS group, with no significant difference in baseline or lesion characteristics between the two groups. And the data again showed that there was a benefit to using IVUS. They showed that the treatment changed in about 80% of cases in the IVUS group. And this included really a change in balloon size, length of treatment zone, and type of treatment as a result of the information that was gained by using the IVUS for imaging. And here you can see, again, they showed a significant difference in primary patency rate in the IVUS group. 83% primary patency rate compared to 63%. So overall, the addition of IVUS, along with good angiography, showed a benefit in terms of more accurate vessel sizing, extent of disease, and patency rate. Here's another study of IVUS related to directional atherectomy. Most of us do angiography on a daily basis, and usually our directional atherectomy is guided by angiography alone. But this is a retrospective study, 114 patients by PK and his team at Mount Sinai in New York. And they showed that of the 46 patients who had IVUS-guided directional atherectomy, they had a significantly lower clinically driven TLR rate of 18% versus 51% when it was guided by angiography alone. And this was at 12 months. And as a result of their data, they concluded that the lack of IV guidance to be a significant predictor of clinically driven TLR at 12 months based on their regression analysis. So again, IVUS guided intervention was showing a benefit here when you're dealing with FemPop in-stent restenosis. There's also a correlation in terms of dissections. Here's another study, small study, about 15 patients where they used IVUS to evaluate de novo FemPop stenoses and non-stent restenosis after atherectomy in patients. IVUS images were obtained at baseline, after atherectomy, and after additional balloon angioplasty. IVUS showed a significantly larger number of dissections in this case, post-atherectomy versus angiography. And post-additional angioplasty, IVUS also saw a significant increase in the number of dissections compared to angiography alone. And so IVUS here was better at really determining the extent, circumference, and depth of dissections compared to angiography alone. And overall, dissections after atherectomy were seen to be underappreciated by angiography alone compared to IVUS. So let's look at some examples. If you look at the image on the left, this is an angiogram without significant flow limitation on real-time imaging. And it looks pretty good on even a static image. You don't really see a significant dissection. But when you look at the IVUS image to the right, you can see there's not only a significant arterial dissection, but there's also significant luminal compromise. And this, I would argue, impacts patency rate and may result in thrombosis at some point. Here's another angiogram. On the left, you can see it looks pretty good, a little bit of plaque, but doesn't look like a significant focal stenosis or even a dissection flap. But again, when you look to the right and look at this IVUS image on the right, you can see there's not only a significant dissection, there's luminal compromise, and then there's a combination of soft and calcified atherosclerotic plaque. So again, therapy has not been optimized here. And here's another example. If you look at this angiogram, you can see that clearly there's a dissection in the popliteal artery. However, it's not flow limiting. There doesn't seem to be any holdup of contrast as it's flowing. There's good wash in, good washout. But when you look with IVUS, you can see there's not only a significant dissection flap, but there's also significant luminal compromise. And so this was a patient where it took almost a couple hours to recanalize an occluded popliteal artery as well as two tibial vessels. The last thing you want to do is leave this alone and then have the patient occlude in a short period of time. And you can see the difference after a stent was placed in terms of the angiographic result, and there was no luminal compromise on post-therapy IVUS. Here's another example of proximal SFA disease treated with angioplasty. Again, you can see there's some luminal compromise or a stenosis here, but it doesn't look that bad. But when you look with IVUS in the video on the right, you can see there's not only luminal compromise, but there is a significant dissection flap with a large false lumen narrowing the true lumen. So this really needs therapy. As a result, tacks were placed to take care of this. And you can see now on the post-tack placement, there's resolution of the dissection flap, and there's improvement of the caliber of the artery. And again, there's the final angiogram to the right. So finally, what about IVUS utilization and amputation rate as well as complication rates? Here's an analysis that was performed on about 92,000 patients from the National Inpatient Sample Database, and they were really looking at all the patients between the years of 2006 and 2011. And what they looked at was in-hospital mortality, amputation, and complications after treatment in patients in which IVUS was utilized. So they really studied about 1,200 patients. Their analysis really showed a lower rate of amputation in the IVUS group and showed that really IVUS was independently predictive of a lower rate of post-procedure complications as well as a lower amputation rate without any impact on in-hospital mortality. So again, showing the benefits of using IVUS. So in summary, we know that angiography is the gold standard for diagnostic imaging and intervention in PAD, but there's compelling data showing that IVUS is better than angio in terms of vessel sizing, determining the degree of stenosis, assessing plaque morphology and composition, showing residual disease and extent of disease, in other words, treating normal to normal, pre and post therapy, demonstrating dissections in terms of luminal compromise, significance, and extent. And IVUS has been shown to be better at showing optimal stent expansion and wall apposition compared to angiography. And we know that IVUS-guided interventions result in a higher patency rate with regard to DCBs, FemPop artery stent placement, and directional atherectomy for FemPop ISR. And there is some data showing a lower amputation rate and complication rate. Thank you. And I want to thank everybody for inviting me for this lecture.